Cerebellar syndrome. General features. Multiple sclerosis, common in routine clinical practice and in PACEs, would be high on the list of differential diagnoses. It is quite likely that her imbalance is due to cerebellar involvement, but you should also consider a spastic paraparesis. The common causes of a cerebellar syndrome are given in Table 16. The patient with cerebellar ataxia may have a head tremor or titubation and an intention tremor in the arms when shaking hands. The patient may also have a slurring dysarthria and use walking aids or a wheelchair. Neurological examination. Gait ataxia. If you have not yet observed the gait, ask the patient to walk a distance of at least 10 m as normally as possible. Make sure that you walk alongside the patient if he or she appears to be very imbalanced. A broad-based, to improve stability, ataxic gait is characteristic of cerebellar disease, but in mild cases the unsteadiness may be apparent only when walking heel-to-toe, tandem walking. In a unilateral cerebellar hemisphere lesion, there is unsteadiness towards the side of the lesion. In truncal ataxia there is difficulty sitting or standing without support. Subsequent examination should focus on the cerebellar system and then go on to examine other features to delineate the cause. NB. In midline or generalized cerebellar disease, an abnormal gait is likely to be the most prominent physical sign, and coordination of the arms may appear normal. Incoordination of movement. Cerebellar dysfunction causes impairment of the process of controlling movements once they have been initiated. This gives rise to ataxia, incoordination, with the following signs. Intention tremor. There is no tremor at rest, but when the patient moves a limb an oscillating tremor develops that increases in amplitude as the limb moves towards the target. Dysdiadochokinesia. Inability to carry out rapid alternating movements with regularity. Dysmetria, inability to control smooth and accurate targeted movements. The movements are jerky with overshooting of the target, as manifested in the finger, nose and heel shin tests. Ataxic dysarthric speech. Speech can be slow, slurred and scanning in quality. In scanning speech, there is loss of variation of intonation and the words may be broken up into syllables. Ask the patient to say words with several consonants such as baby hippopotamus and British Constitution. Abnormal eye movements. Jerky pursuits. Pursuit movements are slow, with catch-up saccadic movements on attempting to maintain fixation on the moving target. Dysmetria of saccades. On attempting to fixate on a target, the eyes overshoot and oscillate several times before fixation is achieved. Nystagmus. This is maximal on gaze towards the side of the lesion and is jerky, i.e. it has a slow and a fast phase. Nystagmus results from damage to the vestibular connections of the cerebellum. Titubation. Nodding tremor of the head may occur, mainly in the anterior-posterior, nodding, plane. Altered posture. A unilateral cerebellar lesion may cause the head, and when the lesion is recent and severe, also the body, to tilt towards the side of the lesion. Hypotonia. Hypotonia is a relatively minor feature of cerebellar disease, resulting from depression of alpha and gamma motor neuron activity. Hypotonia can sometimes be demonstrated clinically by decreased resistance to passive movement, e.g. extension of a limb, by pendular reflexes or by the rebound phenomenon. This occurs when the patient's outstretched arms are pressed down for a few seconds and then abruptly released by the examiner. The arms may rebound upwards and continue to oscillate for longer than expected. Other features. Once it has been determined that the patient has a cerebellar syndrome, neurological and general examinations should be conducted to try to delineate the cause. If the patient has multiple sclerosis, then there may be a spastic tetraparesis/paraparesis, other brainstem signs, e.g. internuclear ophthalmoplegia, or evidence of sphincter dysfunction, e.g. suprapubic or transurethral catheter. If the patient has had a cerebellar stroke, then there may be other features of a lateral medullary syndrome, ipsilateral Horner's syndrome, ipsilateral facial and contralateral limb spinothalamic loss, ipsilateral palatal weakness and contralateral hemiparesis. The ataxia in such cases is ipsilateral and the patient may have evidence of other cardiovascular risk factors, e.g. coronary artery bypass graft scar, atrial fibrillation, or diabetes mellitus. A cerebellar hemorrhage can have catastrophic consequences and lead to rapid deterioration in the patient's level of consciousness due to brainstem compression. There may be a surgical scar over the occiput where decompression has been performed, and this should be looked for at the end of the examination. Cerebellar tumors usually present slowly but can present in a stroke-like manner. The patient may be pale and thin. The commonest tumors to metastasize to the cerebellum are from the lung and breast, and in routine clinical practice these systems need to be examined. Patients with chronic alcohol abuse often develop a chronic cerebellar syndrome that characteristically affects the lower limbs and gait more than the eyes and upper limbs. In such patients there may be signs of chronic liver disease and portal hypertension. Rare genetic syndromes may prominently affect the cerebellum and other neurological systems may be involved, e.g. spastic paraparesis and peripheral polyneuropathy in Friedreich's ataxia. Further discussion. There are many rare causes of a cerebellar syndrome, but common ones such as alcohol and anticonvulsants must not be forgotten and should be mentioned before the rarer causes in giving a differential diagnosis. The examiners may ask you to discuss the molecular mechanism of the spinocerebellar and Friedreich's ataxias, which are part of a group of rare genetic disorders called the triplet repeat diseases because they are associated with an expanded number of trinucleotide repeats in disease states. If you are led into this line of questioning, then it is a good sign. The examiners think you have done well.